Hello and welcome to The Upside. It's a show here in Long Meadow where we talk about all the good things that are happening. I'm Paul Santinello, your host. Today we're going to deviate a little bit because I think we have a topic today that I want to talk about to help inform voters. It's question 1 on the ballot this November. So when you get done voting for candidates, you're going to see, I think there's 4 ballot questions, and this is the first one. It's about staffing ratios in the hospital. So this is a ballot initiative, and my guest today, I have Patty Healey, who's a retired nurse who lives in our area, and Spiros Hatiras, okay, so not too bad, who's president and CEO of Holyoke Medical Center. First of all, thank you both for coming, because I think this is really important for people to understand what they're going to be voting on in about a week or so. Yes. So I'm going to start, and this is, again, it's a ballot initiative. It didn't come through the legislature, so if it's passed, it goes before the legislature, just like the marijuana law did and that type of thing, and then they'll screw around with it after that, right? All right, so let me first, Patty, I'm gonna, if you want to give an introduction and why you're advocating for question 1.
Sure. I've been a registered nurse for over 40 years. Most of my career I spent at Brigham and Women's Hospital in the ICU. But I have worked in the emergency room and surgical settings as well. And I've been involved in this fight to get better staffing in hospitals for almost 20 years. And the law that nurses wrote and are advocating for says that there should be limits to the number of patients nurses take care of in inpatient units in acute care hospitals. And that's based on many, many years of data and research that was done by very notable researchers and academics. They were nationwide, some of the studies, and it showed very clearly, without question, that patients in hospitals have fewer infections, faster discharges, fewer readmissions if they have enough nursing care in the hospital, which means nurses who will have less than 4 or 5 patients. And right now, nurses in Massachusetts have up to 7 or 8 patients. So this bill is our second time around, and we really we believe we need a law in place because we've been unable to convince hospital CEOs and the legislature over many years of bargaining to really address this issue.
Okay, and Spiros?
So what really perplexes me, Paul, is that, and the public, I think, is confused because we talk about implementing ratios as if there's no ratios, as if, sort of the sky's the limit and the nurses get assigned no matter what the situation is, an untold number of patients, and that's not true. I mean, every hospital has ratios, every hospital has limits. In Holyoke, I can tell you we operate between 1-to-1, and there are many patients that are 1-to-1, 1-to-2, all the way up to 1-to-5, sometimes 1-to-6. And it really depends on the severity of the patient. It depends on the time of night. I mean, look, if I'm hospitalized, I want good nursing care, and I know we give good nursing care. Our nurses are fantastic. And by the way, let me say, this is not a sort of against the 4 nurses. I mean, we love our nurses, we support them dearly, But do I really need a nurse to sort of stand over me while I'm sleeping at night, and just because there's a ratio that says there has to be a nurse for every 4 patients? Not really. And I will tell you, the arguments I've heard about, we're doing this because, mortality rates and complications and infections and readmissions and length of stay just doesn't hold water. Because if you look at the data, all the complications that we measure are going down. In Massachusetts, we have one of the best care in the world, actually, in the states and in the world, and complication rates are going down. We're working really hard on all the measures, sepsis, cordis, CLASPs, all the measures are going down. Length of stay is going down. Readmissions are going down. With very few exceptions, readmissions have been going down across the country. And if you ask a patient, honestly, I don't think they would define quality as length of stay. Length of stay is really, for the most part, a financial measure. It means how long does the patient stay in the hospital. Most patients actually, would think that, staying less in the hospital is actually not good care. A lot of times we have patients who actually want to stay longer in the hospital. So I don't think that any of these reasons really are real reasons.
Okay. I want to say this, the less I can ever be in a hospital, the happier I am, no matter what. And the other thing you mentioned a little bit, this is not a question about nursing quality, because the nurses do a great job. I mean, everybody's acknowledged that on both sides. That is, what I mean by that is the nurses are. It's not.
Individuals are doing the best they can.
The best they can,
yes.
correct. And that's what we want to make sure that everybody understands. It's not about
Certainly.
Anything like that. So let me. There's the confusion I had with this when I first was reading this is, and I'll give you a real life example. My father had a stroke a few weeks ago, 3-4 weeks ago, and the issue wasn't the nursing care. It was the number of beds that were available in a unit, for example, and there weren't enough beds in the neurology department where he had to go before he could actually be discharged and stuff. So without, and that, will this bill address that type of thing? And that's my question. Okay.
I don't know the specifics of your father's
Correct, right.
inpatient, of course, but it's a good example. And I just wanted to say to Spiro, too, that in fact, Holyoke Hospital isn't one of the hospitals that's suffering from poor nursing ratios. And it's clear there are a number of community hospitals that actually meet the guidelines that we've written into this law. Holyoke's one of them. A patient who goes to Holyoke Hospital, perhaps your father started there, I don't know, may get the care needed by the nurses in that hospital. But when transferred to another hospital such as Bay State, which does have very poor ratios, nurses do care for up to 8 patients at a time, then even though your father had great care in one place, if he needs to go to another place, why should his care be different? If he's got the same health insurance, he's living in the same community. Some hospitals in this state, which make very high profits, including Bay State, second highest profit in the state, next to Mass General. The care there in many units is substandard. It's substandard according to the guidelines by nurses groups across the country. So what happens in the hospitals where there are beds, like I said, I don't know the specifics, but many hospitals are unable to admit patients to units because the nurses are so overloaded. So that neurology unit may have had an empty physical bed, but the nurses already had up to 7 or 8 patients, and they just couldn't take your father. I don't know if that's what it is, but that's what I hear from from inside the hospital. That's what we know.
And I just want to follow up, because you mentioned a word that you said that they deliver substandard care, and maybe you didn't say it exactly like that, but what do you mean by that?
What I mean is, if a nurse I'm an ICU nurse, so I would take care of 1 or 2 patients. The ICU law passed, we're supposed to get no more than 2 patients, and we're supposed to decide according to the acuity scale that we use. And by the way, this law has an acuity scale to be used by nurses to define what kind of care patients need. So it can fit into that guideline, that grid of how many patients a nurse should be able to be taken care of according to the needs. So it's not rigid and it's not inflexible. The nurses have more control over it. So what I mean is, if a nurse has 8 patients, I'm working an 8-hour shift. I have somebody with pneumonia, I have somebody with a broken leg, I have somebody with multiple medical problems. I cannot take care of the needs of those patients. My care delivered is the best I can give. I run from patient to patient doing the best I can, delivering the medicines, assessing whether their medicines are working, gathering the information, calling the doctor, preparing all that information for the doctor. And a patient has a nurse responsible for that patient 24 hours a day. They might see their doctor. I'm not minimizing a doctor's work, but physically the person caring for that patient is a nurse. And they might see their doctor a period of time. Nurses collaborate with doctors, give information to doctors, where we're all part of a team. But that patient is relying on the nurse. The nurse is responsible for everything that happens to that patient in that hospital. And so when that patient does not see a nurse, a registered nurse, a qualified healthcare professional, for most of the time that they're in there, many things are missed. You don't get to listen to their lungs. You don't get to check their labs. You don't get to explain the problems to the family. It just doesn't happen, even though we know it should happen. And that's why we say care would be better. Overall care in a hospital would be better if nurses were staffed well enough to take care of the patients that they have.
So, first of all, I appreciate, Patty recognizing that, we are in community hospitals, we're staffing, well, and we're doing the best, for
Well,
our
Holyoke
patients.
is anyway.
Holyoke. But then, of course, on the flip side of that, it makes me feel sort of like the baby in the bathwater, right? I mean, because this law does not discriminate between, hospitals that, staff better and hospitals that perhaps are not staffing as high a ratio. And so, just to make this clear, I mean, look, at Holyoke, we have a monitored unit, which is if you have cardiac issues, you're monitored. There, a nurse may have only 3 patients or 4 patients around the clock. Then we have a step-down unit where people go that may have, flu symptoms or pneumonia or something that is less, maybe worrisome. And there, at night, we may drop the ratio of 1 to 6. With this law, what our concern is that it has to be 1 to 4 at all times. And let me also clarify the acuity issue, the acuity tool. I mean, we all talk about the acuity tool. You'll hear the hospitals talking about an acuity tool. You hear...
Before you go, what's an acuity tool? 'Cause you're talking
So
about
the acuity tool is basically sort of an algorithm, a way to objectively determine how much care a patient needs. So, there's sort of like an assessment that's done. So, by the way, is your dad okay?
Oh, he's doing fine, thank
okay,
you. Yeah.
great. So like, I want to bring an example. If you have a stroke, for example, and there's certain severity, indicators, then you require more care. If you're coming in and, you're post an elective orthopedic case, that went really well and you're going to be in the hospital a day and a half, your acuity may be very low. So the acuity tool is to measure that. But here's where the confusion is. The hospitals are saying we should have an acuity tool to determine the right staffing, meaning it should be anywhere from 1 to 1 to 1 to 6. When the bill that's written, when the yes side talks about an acuity tool, the acuity tool, the way it's written in the bill is that it cannot exceed 1 to 4, but it can drop from 1 to 4 lower if the acuity is higher.
That's right.
So there's a downward sort of adjustment, which means more expensive, more difficult to do, but not an upwards adjustment. But I also want to address the issue of the bed. So here's the reality. So Holyoke, we've crunched the numbers to see what would it take for us to staff 1 to 4 at all times and 1 to 1 on maternity and all the requirements in the bill. And we would have to hire 63 or 64 more nurses than we have currently. A nurse roughly costs about $90,000 to $100,000 a year with benefits and salary, right? So that for us is roughly at $90,000, roughly $5.8 million. Just to give you a sense about Holyoke, we're a community hospital, we're not for profit. We have no accounts at the Cayman Islands, there's none of that going on. And as a system between the hospital, the physician practices, and the behavioral health unit, last year we had a profit of $200,000. That's all we could muster last year. Now, hopefully this year's a little better. It was a tough year last year, but at best, we may be able to have $1 million left over, which then we use to buy new equipment and renew. This year we're buying new beds. It's $1.2 million to buy 120 beds, $1.2 million. So the money is just not there. And so what will happen is, also the nurses are not there. We currently have, I want to say, probably 15 to 20 positions that we can't fill. Why is that? Because nurses get jobs at case managers in schools and every other spectrum. We have nurses retiring and nurses coming on, but we can't always fill our positions. So our worry is this. Whatever the date is, January 2nd, whatever it is, whenever the date rings that this now has to be implemented, there's 2 things that can happen. Either you have suddenly 68 more nurses that you can bring on and keep your bed count where it is, or in order to meet the law, you have to reduce the bed count. And for us, I know for sure, Bay State is looking for 120 nurses now, and they're going to be looking for another 200 when this law goes into effect or more. Mercy is going to be looking for nurses. Cooley Dickinson is going to be looking for nurses, and everybody else. I know for sure I will not have 68 more nurses. So what's going to have to happen is we're going to have to say, in order to remain legal, we have to drop our beds from 120 to maybe 95, or whatever the number is, to meet that requirement. Which then means the people in the ED waiting for a bed have to stay in the ED, which then means the people arriving in the ED won't have a bed to go into, which then means the ambulance cannot unload and go back to the community, has to wait. And this is what they call in California holding the wall. It's basically the backups that happen in the ED. So that's to answer your question about beds.
Okay. So let me ask this question. If, for example, let's say the law passes and if the ratios are, let's say, 1 to 4, right? That's kind of what you're mentioning.
They're different for every single unit.
But it's not going to be different for every hospital, correct? It'll be uniform for every hospital?
It depends on the acuity scale.
Okay.
And hospitals define their patients differently too. An ICU patient at Brigham and Women's would not even be in a hospital at Holyoke Hospital. So they're very different patients.
Okay.
Yeah.
But what my question is that you mentioned that at Bay State they might have 1 to 8, for example.
Yes, they report it. The nurses report
Okay.
that.
So if the law were to pass and it sets up a 1 to 4, for example, they either have to, there's only two solutions: more nurses, less beds. Correct? I mean, if the law passes.
No. You know, this.
Well,
you
that's
brought
what-
up a lot of things that about the law, and it's not just about beds and how many nurses. The fact is, in Massachusetts has a very healthy healthcare system, very profitable. Down the road, the hospital there makes about $750 million in the last year. I know Holyoke didn't, but like I said earlier, I opened with. Many hospitals are doing just fine with what we recommend in this law, the number of nurses to patients. So I'm not going to argue just about Holyoke because it's statewide. And the statewide, our hospital system makes billions of dollars, including down the road here in town, in town hospitals in Boston. So there is money to move into taking care of patients in the hospital, but it is being spent in other ways. In fact, our studies that were done by researchers at Boston College and Linda Aiken and others show that if hospitals were able to take 3% out of their administrative budget, that would, in most cases, in the 64 hospitals, most cases pay for the nurses that they need. And hospitals are using Mass Hospital Association is using these incredible scare tactics. There's no data that shows that they will be closing down beds. There's no data, they haven't produced any data at all that shows that they are going to be closing all their services. This is completely scare tactics that they've been using throughout this campaign to frighten people into thinking, oh, if the hospital makes a better experience, better health care inside the hospital, then somehow you're going to lose. Somehow you're not going to have a hospital anymore. And it's simply not true. California passed this law 14 years ago. I know California is not equal to Massachusetts, but they did it. And what they found was that they reduced emergency room times, they reduced, there were 8 studies that show that the nurse-sensitive problems that patients encounter were reduced, and it's clear in the data. The overall cost of healthcare, the healthcare dollars, the increasing healthcare is slower in California than Massachusetts. The premiums for California residents are $100 a year cheaper. The co-pays are cheaper. So something happened there. Nurses were hired, they solved their nursing problem, but no hospitals went under, beds didn't close, the hospital system didn't collapse. And we know that. And we know also that Massachusetts has a very healthy, profitable healthcare system. And we know that healthcare dollars are put into places where they're not delivering health care. And we know that 25% of health care dollars in Massachusetts go into administrative cost. That's dollars, not just hospitals. That's wrong. It's a very large problem. We're talking about a slice of improvement.
When you say it's wrong, but let me go back to my original question.
Yeah.
If there's a 1 to 8 staffing ratio, whatever hospital it is, okay? I don't care if it's
Many
local
of
or
them.
not. Let's just say 1 to 8. There's only one of 2 ways you solve it. If it's either more nursing, right? So it's not 1 to 8, because you have to drop down the ratio per the law, for example, or you have fewer beds, one or the other, correct?
No. If a
Can I try to address it if you don't mind?
Well, I want to just
for a
answer
second?
that
Okay,
question
sure.
because what you're saying is, oh, if you have more patients come in, then somehow.
No, you said for example, and I'm asking because I want to know.
Maybe I don't understand.
Yeah, maybe, give me a shot. I think
Okay.
I'll make it for the viewers clear.
Okay.
So here's the deal. I have a unit right now, and it has 50 patients on the unit.
15.
50. Say I have a 50-bed unit, right? How many nurses do I need today when I staff 1 to 5? 10.
Yeah.
Okay? Now the law passes, It's past midnight now. It's the new day of the new law. I still have 50 patients on the unit. How many nurses do I need now? I need 13. 12 are not enough.
Not on that day. No, not on that.
12
That's
times
not
4.
true.
When would I need them, Patty?
The law goes into effect.
Okay,
on
when
a
it
date,
goes into effect,
But
right.
you're implying that you immediately need many nurses.
No, okay, let me then
that's not
rephrase
true.
it. The
Okay.
day the law goes into effect, I'm going to need 13 nurses for those 50 patients, right? Okay. So one scenario is I have the 13 nurses because guess what? I was able to hire them, I was able to afford them, and I was able to train them in time, and they're there and they take care of the patients. But let's assume, for whatever reason, I mean, we can't fill the positions now. I don't have those 3 extra nurses, right? And I still only have 10. Now what do I have to do? Now I can only take care of 40 patients. So what does that mean? 10 of my beds have to remain empty. That's what we're trying to explain. That it's not, yeah, if you could find the nurses, and I hope we could talk about cost a little bit, but if you find the nurses, you don't have to close down beds. If you can't, though, in order to stay within the ratio, the only thing you can do is operate 40 beds with the 10 nurses.
Find the nurses.
Well, let's talk about finding
Yeah,
the nurses. I mean, we can't even find them now,
3,500
Patty.
a year. 3,500 a year graduate from.
You know how many retire from the hospital?
Yeah. Oh, absolutely.
I mean, I have more retiring than I can have coming, and you know what? You know,
They're
you were an
leaving the
ICU
state.
nurse. Let me ask you a question.
They're leaving the state. We know they're leaving the state. They're telling us that.
All I can say is this: I've yet to come across an unemployed nurse. And you know what? And no other state has ratios. Massachusetts has one of the safest healthcare in the country. I don't know why they would be leaving Massachusetts to work in another state in an ICU. It doesn't make any sense. But I hope we talk about cost, if you don't mind, because I think cost is really why this is becoming calamitous. It's not just that we don't think we're going to find the nurses. But let's say we find the nurses. Let's say Patty's right, and somehow the nurses, come all back to Massachusetts, and we can hire them. Cost is an issue, and you know there's been like 2 numbers out there that are vastly different. One talks about $1 billion, and one talks, I forget what it is, 47
million, yes.
And the viewers, I think, are confused. And you hear studies this, study that, how do we study? May I offer something to your viewers that they can actually, without a study, on the back of a napkin, figure out which number is right? Here's which number is right. We already established that 90 to 100,000 the cost of a nurse, right? So $47 million buys you about 50 nurses. 500 nurses, sorry. You can do the math. 47 million buys you 500 nurses. Now, do you know how many nurses work in acute care hospitals in Massachusetts? Patty, you know the number? It's well over 60,000. I mean, we're talking about, we have 100
Hospital inpatient nurses?
We have a ton of nurses.
A lot of nurses, but they're not all working in the hospital.
Okay, but we have over 100,000 in the state. When I'm talking about just acute care. Now, either way, whatever the tens of thousands, whether it's 40,000, 50, 60,000, whatever the right number is, the 500 nurses that the M&A is telling us, that's what the cost is, represent less than 1%. We're talking about probably 0.6% of the nurses already working in hospitals. So is the yes side really telling us that we're 99.3% staffed to where we need to be, and all this hoopla, the millions of dollars we've spent on this campaign on both sides, and all this calamity, it's just
We're not
another
spending
point.
millions of dollars.
Oh, I know how much you spent, Patty, and it's in the tens of millions. Okay. Commercials are not free. I mean,
we don't have as many as the hospital association.
The point is that is this all happening for 47 million? I will make a commitment today to the viewers, and I think the MHA we're perfectly fine to do this commitment. We'll staff up to $47 million and then stop and say this is it. This is what you get for $47 million. That's 500 nurses statewide.
Hold on, I'll let you
So how can it possibly be? Think about this, right? I mean, that's what the M&A wants us to believe, that it's going to cost $47 million. That's only buying you 500 nurses. How could we only be 500 nurses short and make such a big sort of...
Spiro,
right?
the study that you're referring to, that 900 million, was grossly...
No, I'm talking about the 47.
I know you did. I know you did.
Patty, explain the 47 to me. It only buys you 500 nurses. How can you and the M&A say that all we need statewide is 500 nurses?
I'm not saying that. I'm not saying that.
But that's what you guys saying the cost is. So either the cost is wrong,
the cost is
or the whole campaign is wrong.
by a researcher who looked at where the real
does that sound right to you? Does that 47 million right to you?
I'm going to believe my researcher.
500 nurses, that's all we need?
But that's not what I want to talk to you about. We had researchers do that. The hospital side had a study done that was grossly inflated, and its cost costed out is $300,000 per nurse. Now, $300,000,
no.
if you divide up 900,
No.
Close
It's
to
not.
$1 billion.
It's
Yes,
not.
it is,
Hold on,
Spiro.
just one, hold on.
And we don't have a nurse shortage here.
Okay,
There is not
but
a
as
nurse
far as the
shortage.
hospital number, or the HPC number for that matter, I can do that in the back of a napkin too. I told you that
Well, why can't you-
I need 68 nurses
If it's
in
that
Holyoke.
simple, why can't you find nurses?
Hold on a second.
We're saying
There's
you can't find
60
nurses because you are
Okay.
overloading us
I
at
need
work.
68 nurses at the Holyoke Medical Center. I know that because I personally crunched the numbers, right?
Mm-hmm.
So I know the number is bigger than the 500 nurses that the 47 million buy. So the HPC estimated somewhere in the 3,000 neighborhood. The hospital association thinks it's like 4,000 nurses. Now, if you take that number, 4,000 times 100,000, that's already 400 million. And you know what's going to happen? The reason the number climbs to almost $900 million is because not only do you have to hire $400 million in new nurses, train them, spend all this money recruiting them. But you know what's going to happen to the market? When you suddenly need 4,000 nurses, everybody's salary is going to jump 10%.
We're saying
Everybody's
it's not
salary.
4,000 nurses. I don't know where you get
3,000.
your figure. I believe you, that's your figure. How many nurses do you employ right now?
We have probably 450, 500 nurses. We need 68
You have
more
500 nurses at
Somewhere
Holyoke
in the
Hospital?
400, somewhere in that neighborhood.
Registered nurses?
Yes, we only have nurses.
Because how many beds in the hospital?
120.
So that's hard to understand because Berkshire Medical Center, which has more beds,
But
has
the
about
math
300
does
nurses.
not work.
So I'm,
the
I-
47 million Patty.
I'm not believing your math, you're right.
Well, I mean, it's easy
Well,
to do. We have
look.
a calculator. It's 500 nurses. How can we possibly say
Why
we
can't-
made all this ballot
Why
question
can't-
over 500
Why
nurses?
can't other hospitals hire, why can't a hospital with $70 million profit in 1 year hire their nurses?
I don't have $70 million. Go
Why
ask
can't
them.
Trinity Health, $1 billion this year they made, and they own the hospital right down the street, Mercy, who claims they have to do layoffs. Mercy and Providence. When Trinity bought Mercy and Providence, they laid off staff and they are threatening layoffs. $1.3 billion at Trinity Health. That's a nonprofit that owns that. South Coast Hospital Group on the South Shore, $51 million. We can't afford nurses. That's where nurses in a for-profit system are taking care of 7, 8, 9 patients. And it's simply, I understand your side, but it's simply not happening in the rest of Massachusetts. We know, because from surveys from nurses, surveys that show that nurses are very unhappy with their jobs. They leave them. The average new nurse leaves a job in Massachusetts after 3 years. And that's why there's a open door, a revolving door, and hospitals are spending a lot of money to retrain nurses. They're leaving as soon as they find out it's that bad. Why does Bay State not have enough nurses? Because people won't work there. Nurses talk. We know, in this area in the Valley, everybody knows what kind of employer Bay State is and what kind of patient load you're going to have there. And my question is, if there is an answer to this question, the first time any answer has come up after we have bargain union contracts. We've been on committees. We have been at the State House. We work with the legislature for 15 years. This is our second time around writing a law and trying to move this through. It's not like we haven't been trying to figure out an answer to this question, but it's fallen on deaf ears. CEOs and hospital executives have refused to solve the problem, and they have the ability to do it. And saying you don't have enough nurses in the state, we know there are thousands of nurses graduating here. We know that nurses will take, and they've said it in many, many surveys, they will take a full-time job if the workload was reduced and they could give the care that they should be giving in a hospital. And the data's there, the nurses say it. And it's not just the Mass Nurses Association. Massachusetts Nurses Association, nurses like myself have the resources to look at these problems in nursing and come up with a solution. But we're looking at all hospitals in the state. All of us have to use the hospitals in the state. Why should it be that my Blue Cross card will be, at one hospital I'll get one standard of care, but if I go to another hospital in Massachusetts, I will get another standard of care. It's equity as well. People should be able to get the same standard of care throughout the whole state, and they're not.
So let me ask you a question. There's millions of dollars every year come from the state back to hospitals for different programs that they run. So if companies in hospitals are making $1 billion or $750 million, and the one that was highly publicized in our area is that that Bay State received $1 million or so forth, and that type of thing. What current and to me what I don't care for is a commission that's going to establish things for medical care. That's a personal thing. But my concern is...
Are you talking about the commission that's already in existence in Massachusetts that will
Question 1 says there'll be a commission established.
It already exists, yes.
Okay.
Yeah.
So
it's already there. But
right, so there's already regulations that are put upon hospitals for patient care and that type of thing. And I don't know how detailed they get, so I'm not
very detailed. Many regulations,
that I go into that. Okay. So why is it then that you say certain hospitals, and I'm not asking you for the grand picture of this, why are hospitals, if they have a 1-to-8 patient ratio and are able to do these kind of things where they're not delivering the quality of service, and you've acknowledged that Holyoke is not one of those, why isn't there more pressure on them to change that? I mean, unions negotiate, I know that, right? But there's an issue there where it is negotiated.
This is a worldwide movement, believe it or not. Countries all over the world, nurses are talking about this one issue. And there are at least 7 states working on legislation right now. Nurses in other states are working on the same legislation. This isn't new. This is maybe news to you, but this is not news.
No, I'm not saying it's not news to me. I'm just asking that there's already regulations in place that
not for staffing, not for hospital staffing. There are not. And
no, right. And I didn't say that there was. I'm just saying that
there are lots of regulations. Why should we have more?
If nurses, when you say that nurses are leaving the state, okay. How many nurses are leaving the state on an annual basis?
We know that, I don't know the numbers, but I know that Boston College professors have reported that their students leave the state because they cannot find a full-time job. And that's one of the problems in Massachusetts. There are fewer full-time jobs posted in Massachusetts for nurses and inpatient facilities than in other states. So new nurses who graduate, who have college debt, and need a job after years of college, leave because they can't find a full-time job. And in fact, I look regularly at the hospitals in the area, and most post part-time jobs or per diem jobs. They don't post full-time jobs. And nurses who are looking for full-time jobs will leave the state in order to get a full-time job. We know that because we can see what the postings are. We've seen it from the reports from the hospitals. I saw it in Boston last year. I saw nurses, young nurses who I was training, students, would say, "How can I get a job? I can't get a job. I have my resume and everywhere. I can't even get an interview." And that's anecdotally, that's really true. And Mass General, what they did was they started a program of hiring new nurses with very substandard wages. So they hired new nurses, but not at normal wages, very, very low wages, because they knew they could do it. So those nurses didn't stay. They left. They learned how to be a nurse and they left. So they're closing that program. I mean,
And I asked that same. I'll let you answer that as well.
Yeah, look, I'm really what it boils down is I'm worried about really 2 things. One is that we're not going to have the nurses, but I also worry about the ability to survive this financially. I mean, as I said to you, Holyoke, we've spent 5 years, trying to expand into the community, and do services that the community needs. And I will tell you that many of those services, I mean, we do because the community needs them. I can tell you there are services that we actually, excuse the expression, losing our shirts on. But we're doing it because the thought of not providing this to the community is unpalatable. That patients would have to leave Holyoke and go, say, to Springfield or somewhere else to get the service. And I also wanted to tell you something else, and I want to tell your viewers this, that there's a lot of this, rhetoric on both sides. And in fairness to Patty, I'm sure there's rhetoric always on both sides. But this idea of hospital administrators don't care, and I started as a physical therapist, okay, and I saw patients on the bedside along with nurses. I had a patient load. At times, we couldn't control how many people are going to come to the hospital at any given time. So there were times when, I'm supposed to have 10 or 12 patients, and I ended up having 15 that day. And you know what? We banded together and did it. And the fact that we now, because we're hospital CEOs, we don't suddenly care for patients, we don't care for safety. I mean, that to me is sort of the worst part of this whole debate. I will tell you that my performance evaluation by my board, 85% of it is based on non-financial outcomes. In other words, My goals are safety related, sepsis, outcomes, qualities, CLASBs, all the things I talked about. Patient satisfaction, which is the HCAP scores we get from Medicare. Employee engagement, which is our own engagement scores, and services provided to the community. Only 15% of my evaluation has to do with financial metrics. And it has to be there because, who would hire a CEO and not want to make sure that they're not going to run the place into the ground? But 85% of what I'm judged on has to do with the patient care we deliver and what our patients say and what our staff says, and nothing and quality and safety. So, there's a whole care team that cares for patients, including the administrators. My nurse manager, she's an ICU, she was an ICU and ED nurse. Oftentimes nurse managers are being attacked in this campaign because they're not real nurses anymore, they don't treat patients. But you know what? Everybody goes through a progression in their career. And our chief nursing officer is an amazing woman. She's done amazing work through her life, and she cares for the patients, she cares for the nurses. So I just hope that, I not want to minimize the issues that Patty's bringing up necessarily. I think that there obviously is work to be done. If there was no work to be done anywhere in the state, I don't think we would be in this position. I just don't think this is the right way to do it, because this is sort of a one-size-fits-all thing that fits really no one. It's going to really hurt community hospitals. I'm really worried about our community hospital, and I think there's better ways to come together and solve the issues where the problems are, if there are any, where they are, and solve them there.
Maybe you should be running the hospital. I mean, you're a nice guy. You like your staff.
Steve, you didn't hear
You're
this
not making
from
$4 million either, though, like some of the other CEOs. I mean, really?
See that?
4 or 6 million?
We just got your
Come
new job
on.
too. How's that for you, Doc?
I'd love to work
That's
with
wonderful.
you. You sound like the
I
kind of
love to
guy I
work
want
with
to
Patty,
work
so how's that?
But the truth is, you want to think of better way. Tell me what that better way is, because we haven't heard it. And I love my job. I'll never do anything other than being a nurse. But when I have to go in and see that people are going home with bed sores, or they are not able to understand their medicines because we didn't have time to talk to them before they went out, and they're cardiac patients, that is simply wrong in a country where we have the resources and the ability to give the best possible care.
No question, Patty. I agree with you 1,000%. It breaks my heart when a patient is not taken care of. On the flip side, I come to work for the letters we get from the patients that say, hey, you guys were amazing. We love the care you gave us.
I do the same thing.
I'm
there
really
for my
worried, though,
patients.
that in order, that this is sort of a shotgun approach to fix it, and we're putting it on the
Not
public.
shotgun, 20 years. Shotgun means,
but but to me, what it means is you're taking a broad shot at everyone to fix a problem that maybe not everywhere. And
because
I'm worried,
it has to be a law.
and I'm
It has
really
to be a
worried
law.
that we're putting it on the public. That really everyone I speak to, from seniors to even nurses, are confused about this.
course they are.
And I think that we're putting it in the hands of the public.
Why? Why did we go? Why
You know
did we
what?
do
I don't
that?
know why it broke down. To be honest, I wish we could
Because
continue talking.
It's been years that we have done this. Union contracts, strikes. We've had 5 strikes. What were the strikes over?
Well, I don't know, Patty.
Staffing.
Yeah.
Staffing is what it is. It's not like hospital CEOs don't know that this is a problem and that we haven't told them and we haven't met with them. This is a desperate measure for desperate times. No one wanted to come forward to do a ballot question like this. But this law was written as a law years ago that we worked with legislators around, and the Mass Hospital Association worked so hard to do everything they could to diminish our ability to even speak in the
I
legislature.
truly believe that, as you know, the Massachusetts Hospital Association has changed leadership. I truly
So
do
you're gonna-
believe. I truly do believe that this new leadership we have with Steve at the MHA is receptive to continuing the dialogue. I just think that timing worked out the way it is, and I mean Steve just got in there as this was underway, and I don't think we've had a chance to really sit down and talk and figure out how we fix this. And again, my concern is that this is just going to be too blunt of an instrument.
Well, they certainly spent a lot of hospitals' money to fight this initiative, and instead of sitting down and talking to us about it. And I think that I'm not willing to wait any long. Time's up. Time's up. It's been too long. I've been doing this 40 years. I started at Boston City where I had 20 patients. And does that sound ridiculous? Yes. It was a public hospital, though.
I want to, I debated about whether doing this as a show, and what I mean by, not because of you guys, because I didn't know who I was going to invite on, but it's such a it's an important issue, number one. And number two is there are sides to that argument. There's both sides to that argument. Nothing, and I don't want to say this in the wrong way, but when things come due out of frustration or bloom out of frustration, you know, there's good and bad with everything in the sense of there should be and I'm not knocking the process, so to speak, that the nurses went through, but there really should be a lot of public education about this. And I think people have a great interest in this because, you know, quality of life issues, right? I mean, that's mainly what we fight for every day by going to work, and everybody does to improve life quality and that type of thing. So it's not an easy topic to discuss on a
Very
little
topic.
show.
Yes,
Oh no,
for both
you
of us,
listen.
yes.
But yeah, I truly want to say thank you. I appreciate you both coming on because I know it's not easy when you're sitting in a room with someone who's on the other side of the table, so to speak, but making your points. And I think that what you both have done today is given people something to think about. And what I would encourage everybody to do is to go out there and read and learn about as much about this, not just from the Nurses Association or from the Hospital Association, but look at these issues.
SafePatientLimits.org.
Yeah, absolutely.
So-
I will tell you, my hope, just maybe to close on the positive from my end too, my hope out of all this process is this. Obviously, first and foremost, that, you know, we don't vote this into law, but that this process has created enough education, enough dialogue with the public, with the legislators, with everyone. I mean, look at the extent of this dialogue, that as soon as this is voted down, we sit down and we figure out how do we address the issues that Patty and others have brought up that may be and very well be real issues. How do we make sure every patient gets, you know, even better care than they're getting today? And I think that, to me, would be the positive out of this, that we educated a broad spectrum of people, both on the public side and on the political side.
And my hope is, just as in California, where this law did pass and there have been improvements in outcomes and lower costs, that when this law passes, that we will finally have a dialogue with our hospital managements and executives about how to implement the bill in a fair way, but that everybody can live with, but that the end result is that patients will have a nurse at the bedside to take care of them, and I'll be able to stay and do my job the way I want to.
Okay. Well, first of all, Spiros and Patty, thank you again for coming. I appreciate it.
Thank you.
Thank you.
I absolutely agree.
Pleasure.
You should be running all of our hospitals. Please. All right. No, we're gonna get that resume out there. I want to thank you guys for watching. I hope you've gotten something from this, and it helps you make a better decision, whatever that is, on November 6th, I believe it is, on Tuesday, November 6th. So again, thank you for coming. Thanks for watching The Upside. Have a great day.
Thank you.
Thanks very much.
Thank you.